Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Welcome to the Gastro Girl podcast. Today, we're thrilled to have an incredibly special guest joining us to discuss IBD and pregnancy, what to know from planning to delivery. Joining us today is Dr. Sunanda Kane, a world-renowned gastroenterologist and IBD expert. Dr. Kane is a professor of medicine at the Mayo Clinic in Rochester, where she has dedicated her career to improving the lives of patients with inflammatory bowel disease. Hey guys, we've got some big news for your gut health. Say hello to the Ask Gastro Girl app, a revolutionary new tool designed to help you take control of your digestive health and feel your best every day. Why is this a game changer? Because we're leveraging AI to guide you with instant evidence-based answers for all of your gut health questions anytime, anywhere. It even has personalized meal plans and smart tracking tools so you can stay on track and meet your health goals. Check it out on the App Store or Google Play, where you can get access to a free 3-day trial. Thank you for joining me today, Dr. Kane. So happy to have you on the show today.
Oh, I'm thrilled to be here.
Well, this is such an important topic. Living with a chronic condition is challenging enough, but if you're a woman thinking about getting pregnant, there are so many things that you need to consider. And what should women with IBD know before they start planning for pregnancy?
Yeah. Well, it's also important to not forget about the men. Men who have IBD, who want to be fathers, have questions as well. So want to make sure that we give some appropriate time for their questions as well. But it is important for women to have the most up-to-date information and science and evidence so that they can make some choices and maybe even educate their providers who not necessarily have the resources or the time to be up on, this very niche but clinically important area of care. So I'll start by saying that while we spend a lot of time talking about this and studying it, that ultimately that providers probably spend more time worrying about their pregnant IBD patients than they need to, and that the majority of pregnancies go just fine, and that ultimately that where there are key differences are the important things to point out, but that overall, I think the take-home message here is that we spend a lot more time worrying than the true reality of things. But there are certain circumstances that it is important for us to just be mindful about, and that we're thoughtful and proactive. And so that's what I want to share with the audience. So when we're thinking about, I think I want to start a family. The important considerations there are, is my disease under good control? So somebody who is having flares, who is stuck on steroids, this is not a good time to be thinking about getting pregnant. That there are some women who say being pregnant controls my disease. And that is a real phenomenon, but it doesn't hold for everyone. So that is not a good rationale for why you should get pregnant. And it's a little bit beyond the scope of this podcast to talk about why we think that women actually might get better if they're pregnant. But just suffice it to say that can happen, but for the vast majority of women, that's not a good idea. So getting your disease under control is the important thing. And it should be under control. And that means that under control means that your labs are normal, that you have no symptoms, and that you're not on steroids. And that should be for 3 months before thinking about getting pregnant. Active inflammation makes your eggs less healthy and can throw off your menstrual cycles. And so being irregular may make it harder to get pregnant. But interestingly, when you look at fertility rates, it is surgery that changes the fertility rate, not necessarily disease activity. Certainly no medications will impair fertility, and having controlled disease actually can help your fertility. So any medication that is helping to control inflammation will help your fertility. And really, it's a history of surgery that may decrease your fertility. So if you are not trying to get pregnant and you think, well, I have IBD and I've had surgery, that's birth control enough. No, that's not true. That a lot of unplanned pregnancies occur. And I think it's just important to, whichever side of the aisle, political aisle you sit, that it's important to understand what state you live in and what the laws are in terms of getting getting some reproductive health. If you are not interested in carrying a child, what your rights are, and that understanding that if you have IBD, even when it's well controlled, that you are considered high risk. And why is that? Because you are more at risk for having a child that is preterm and that is small for gestational age and is low birth weight. Having said that, you are not at increased risk for having a child that has a birth defect. So I think that's usually so what women ask me is my child going to have a birth defect? No. 3% of pregnancies in the United States today results in some sort of birth defect. That is my child going to get IBD? That there is only a 3 to 5% chance that if you have IBD, that your child will. If the father of this child has IBD as well, that the chances go up to about 35%. So this is not a genetic disease where you are passing it along like you would for something like cystic fibrosis or sickle cell, something like that. So that's the second question that I get asked. And then the third is, what's going to happen to my disease while I'm pregnant? Am I going to flare? And so I think that those are the important considerations to think about before you get pregnant. Again, that nature has a way of surprising us, and that we can do all the planning we want, and that it doesn't necessarily mean that we're going to get pregnant when we want, or that we get pregnant and we didn't expect to.
This is great. And I'm so glad that you raised the important point that men are affected by this too. And as we're talking about the pre-conception planning, what are the considerations for a man who has IBD?
Sure,
And does that affect fertility, like the ability to?
Yeah. So actually, this is really simple for men, but I think it's important that for them to understand that that IBD medications, for the vast majority, do not affect male fertility, with the important exception of sulfasalazine, that does affect sperm count and motility. So, and it is not dose related. So any male who is on sulfasalazine, it will be harder to father a child. It's not impossible. The sperm are healthy, but there's just fewer of them, and they swim slower. So if there is an issue, and it's not dose related, so you can be on just one tablet of sulfasalazine or 4 or 6, and the same thing's going to happen with sperm health. That surgery doesn't matter for men, and that really what affects sperm health is alcohol and cigarettes. And so those are the two biggest risk factors for poor health. So otherwise, there are not issues with sperm health or fertility with men. So I think that those are the two big concerns that they have. Erectile dysfunction is not related to IBD. It is related to other concomitant or associated conditions like high blood pressure and diabetes, and depression. But again, medications that we use to treat IBD do not affect erectile function, and IBD itself does not affect erectile function.
Great. So what are some ways patients, women and men who have IBD that are trying to have a family, what are some ways that they can optimize their health pre-pregnancy or pre-conception, especially in terms of nutrition and medication? Do you have any tips for them?
Yeah. So if you are anticipating getting pregnant, that I recommend all my patients go on a prenatal vitamin, just for the extra folic acid and iron that's in a prenatal vitamin. That a well-balanced diet is important for all of the different nutrients. So a lot of our patients are on restrictive diets, whether it's for health considerations or mechanical ones because of stricturing, or short gut, or the propensity towards diarrhea. That it's super important that you are eating a well-balanced diet and not a restrictive one. And there are good data in the fertility literature for Mediterranean diet, separate from the IBD literature about Mediterranean diet being a healthy, good diet for increasing fertility. So again, not being on a restrictive diet that you are restricting the number of calories, the amount of fat, and the nutrients. It's super important to be thoughtful of that fetus that you're going to carry ahead of time.
Great, thank you. So now that a woman finds herself pregnant, which is exciting, what advice do you have for, one of the biggest questions that women have is, can I continue my medications while I'm pregnant?
So if you look back to our early data, so back in the early 90s, when there was a revolution in terms of treating IBD, and that's when biologics came onto the scene, that we said, so biologics cross the placenta and the baby's going to get exposed. You have to stop your therapy during pregnancy. Well, okay, that we thought that made sense, but then of course, we've now had these therapies available to us for greater than 2 decades now, right? So what we have studied and understood is that, yes, they cross the placenta, but stopping therapy during pregnancy puts the mom at risk for flaring. And it's a sick mom that is the worst possible scenario for a pregnancy, as opposed to the therapies that she is exposed to. So what we understand is that stopping therapy actually is detrimental. So we've done a complete 180, and we have said, don't stop. Take your medicines at their scheduled times to ensure that you are well. The baby will be born with some of those biologics on board, but we have studied those babies now going on 12 and 15 years, and we understand that there is no detriment to those kids with being born with these therapies. They are metabolized away very quickly. That they when they get their immunizations, that they are able to convert those immunizations appropriately, that they are not at higher risk for abnormal immune systems. They are not more at risk for cancers, for other infections, and the like. So all of those considerations and outcomes that parents are worried about for their children just have not come to bear, no pun intended. So that all you do is risk maternal health by stopping therapy.
Now, I know you were part of the PNO, which is a global consensus conference on IBD. Is there anything new that patients should be aware of? Are there any medications that patients should avoid or maybe change up during pregnancy?
Right. So Jackie, thanks for bringing that up. So we thought it was super important that that on a global scale that we understand the literature and the science. And so back in May 2024, we put together a global consensus conference. There were 39 experts around the table, both virtually and in person, and that this conference included not just gastroenterologists, but colorectal surgeons, neonatologists, maternal fetal specialists, and then we actually had a neonatal pharmacist at the table. And we had patient advocates.
Yes, I saw that.
represented.
It's so great.
And so the 39 of us, we went through 8 different clinical scenarios and did an extensive search of the literature, came up with consensus statements, voted on that, and put together a guideline that is literally global, that we had representation, not just of those different specialties, but also of all the different continents. And so, so we anticipate the publication of these guidelines, hopefully before the end of 2024. The manuscript is completed. It's been submitted to 6 different scientific journals all at once. And so there would be no excuse for anyone to not have seen these, because one of those 6 is an OB-GYN journal. So not just GI. And so a lot of what we talk about would be applicable to the folks that are on biologics for rheumatologic and dermatologic conditions, not just GI. So we are very excited about the fact that as a world, we have come together to say these are the recommendations. And basically, again, the bottom line is that that fertility is affected by surgery, that medications that for the most part are to be continued and are safe to continue, and also initiate during pregnancy to get disease under control. That children born to moms are going to be more likely to be preterm, that they're going to be small for gestational age, and also low birth weight. Having said that once they are born, they catch up with their milestones very quickly to their peers, and that their APGAR scores are normal, and that there is not an increased risk for the birth effects, which ultimately is what parents are most concerned about. Let's talk just very quickly before I forget, and while we're talking about the neonates, a very important update in those guidelines is the issue of rotavirus vaccine. So what we had said was that children who are exposed to biologics while they are in utero should not get live virus vaccines for the first 6 months of life, just because of the consideration of them being born with some of these biologics in their bloodstream. The only 2 live virus vaccines that any child would get before 6 months of life in the world are rotavirus and TB. We still say that they should not get TB vaccinated. However, there are new data that say that, guess what? Rotavirus vaccine is fine. And we give that after 12 weeks, but before 20 weeks of birth. And so that 12-week window seems to be completely fine for most of the biologics, because the kids have metabolized the majority of it away already. And that's what we've learned with continuing to follow these moms. And staying cognizant of the questions that we need to continue to ask, and we are answering those questions. So now we say that if you want to give rotavirus vaccine, that is okay. So that the only one that you should not give is the BCG for TB, because it is a live virus vaccine. Now, there are endemic areas around the world, and those areas, it needs to be a case-by-case basis for what mom is getting treated for and with during her pregnancy. There is the ability to check drug levels in the children. It's just a blood test. We usually don't like to put little kids through blood tests if they don't need them. But in an endemic area, the question might still be clinically relevant to discuss with the gastroenterologist, the obstetrician, and then a pediatrician. But there are ways to mitigate that question and the concern. But fortunately, most of the world are not in a TB endemic area. And so the rotavirus is now acceptable.
Well, thank you for that. And so do you have any insight or sneak peek at the guidelines? Are there any recommendations that they give for patients on managing IBD symptoms if they flare up during the pregnancy? Is there anything new, or what do patients need to know about this?
The only other new thing that's going to be in the guideline. So again, that the guideline is based on literature, science, papers, and that for the most part, it is just a culmination on a global scale of everything that we understand, which is about the fertility and then the management. So the rotavirus vaccine is new. And the other thing that is new is the recommendation of starting a low dose aspirin around week 12 through week 32 to prevent or decrease the risk for preeclampsia. Because we do know that women with IBD if they are pregnant, are at increased risk for preeclampsia. There are other risk factors for preeclampsia, but IBD in and of itself is a risk factor enough that we say that they should be on a low dose aspirin. So we have done the studies. Dr. Mahadevan understood that people were going to be concerned about starting aspirin because it's considered a nonsteroidal anti-inflammatory. Is it going to cause a woman to flare, to bleed, and the like? And the answer is no. So there's a big upside with very little risk. So that is the other important new piece of evidence and the newest recommendation that will come out of the guidelines. Otherwise, the guidelines are very much what people would expect and what we have been educating and touting for a long time now, which is that that most pregnancies are going to go just fine, that you should continue your therapies through pregnancy, that management of disease during pregnancy is paramount. And so whatever it takes to get your disease under control, whether that is the need for steroids, that we will do it. However, if we think those steroids are going to be longer term, meaning more than 2 or 3 weeks, that we will start a new therapy to get disease under control, that we would continue it through pregnancy. That we know that women can actually get diagnosed during pregnancy. And it's okay to do scopes if necessary. We use a lot more ultrasound now in IBD than we did before. That's a really nice way of assessing the bowel. But that if you need cross-sectional imaging, that you can do MRIs without the gadolinium, and just talk to your radiologist. If the radiologist says no way, you can do CTs if you shield the pelvis if you need to, and that stool studies like calprotectin can be helpful. That pregnancy doesn't affect calprotectin, so that that if it's elevated, it means there's inflammation, and it wouldn't be because of the pregnancy. That we want to see our moms at least during that first trimester. So again, what do I recommend to my women patients? That if they get pregnant, they need to tell me. They need to tell me within a short amount of time after they find out, so that we can be proactive in making sure that they start that aspirin, that they are on a prenatal vitamin, that their disease is under the best control that I can make it, and that we have talked about what her diet should look like, because again, one of the risk factors for women with IBD is that they don't gain weight during their pregnancy, and that is bad for the neonate. And so you are literally eating for two. So how is it that we are making sure that you are gaining weight? Because your baby might be gaining weight, but if you're not, it means that the baby's stealing from you. And at some point, that balance is not going to work out mathematically.
Yeah, no, Dr. Kane, I'm glad you brought this up. And I love that as a gastroenterologist, you're so involved in your patient's pregnancy care. And how do you work with the patient's OBGYN and planning for a safe delivery? And are there specific considerations in deciding between a vaginal delivery or a cesarean section?
Yeah. So I'm glad that you're sort of keeping me on goal here, so that we cover at least a little bit of every part of this journey. So that there are very good data to say that women with IBD are at quote unquote increased risk for having a C-section. And most of the time that's because the OB has said, oh, you have IBD, you need a C-section. And so it is not for GI reasons, it's more for the obstetric reasons that we see that statistic. If you have ulcerative colitis, there is no GI reason why you have to have a C-section. If you have Crohn's disease, that if you have perianal fistulas, that would be a rectal stricture. That would be a reason why you should have a C-section. Otherwise, just having Crohn's disease of your small intestine is not a GI reason why you have to have a C-section. What I counsel my patients is that, okay, let's talk about mode of delivery. A lot of women want to push. They want to do it naturally. And that, again, unless there are those exceptions, meaning that you have Crohn's, where you have a fistula, a perianal fistula, or that you have some sort of rectal, active disease stricturing, that I'm gonna say, okay, it would be an obstetric reason why you would need a C-section, not GI. I do get asked whether a woman can have an enema before she starts to push, and that's fine. I want to know who that patient's obstetrician is or midwife, so that we can have a discussion proactively with the patient in the center of that discussion of, what the planned mode of delivery looks like. Obviously, things happen where there can be prolonged labor. That does not appear to be a higher risk in an IBD patient, because I get asked that as well. That again, if there's prolonged labor, if there's neonatal deceleration of their heart rate, if there's a concern about breech, something like that is more OB focused, then a C-section is appropriate. Let's say that that you've got a busy lifestyle and you want to have a planned C-section so that it works around whatever else is going on in your life, then that's personal preference. And again, that's a planned C-section because of that consideration. That women who want to nurse should. That the vast majority of medications are fine to continue and don't cross into breast milk. There are multiple reasons why women should nurse. And there's actually multiple reasons why they should have a vaginal birth rather than a C-section. If you are going to nurse, that lactation cookies are fine. Now, some of them contain a lot of fiber. They might contain a lot of lactose. So be mindful of what lactation cookies that you might be eating. And so make sure that you know the recipe of what goes into those. Fenugreek is an herbal supplement that is recommended by lactation consultants to help with milk production. That I don't recommend because it can make you bleed. And it can confuse the clinical picture if you're bleeding, but your disease is not under control. So lactation cookies, okay. Fenugreek, not.
Along the lines, I was going to ask about this, but you're just so amazing that you just know what I'm going to ask before I ask it. But breastfeeding and IBD medication, is there any medications that a woman shouldn't be on if they want to breastfeed, or how do you counsel your patients for that?
So as of November 2024, that there are certain antibiotics that are considered not compatible. And those would be the ones that perhaps are getting used if you have an infection post delivery, or if you have a J pouch, or you're using antibiotics for abscesses or fistula treatment. And right now, we don't have any reliable data about concentrations of what we call the small molecules, which are the JAK kinase inhibitors and the S1P. So that would be brand names here, would be Xeljanz, would be Rinvoq. We don't know. We say to continue. We say that if you are going to continue those through pregnancy, that you should be followed at least with a consultative visit at an IBD center, but that you should not nurse on those therapies because we just don't know yet how high the concentrations are in breast milk. The other ones are Velsipity and Zeposia. So right now, those are ones that we don't recommend. For those folks who are maybe listening in Canada or in the European countries, filgotinib is another small molecule that we don't recommend. There are issues with sperm health with filgotinib, and that is why it is not FDA approved in the States, but is available in other countries around the world.
This has been such an enlightening conversation, and it's not meant to be the be all end all. We want to present information so that patients can have educated discussions with their healthcare providers, whether it's an OB/GYN or a gastroenterologist. Can you just, this is such an important time in any woman's life, but even more important for a woman who has a chronic condition like IBD. Do you have any resources or support systems that you recommend for expectant mothers? And also, how can patients advocate for their needs to ensure that all their healthcare providers, their OB/GYNs and GI specialists are collaborating effectively?
So, great question. The internet can be an amazing place. It can also be, a rabbit hole that is super dangerous. So, reliable resources are going to be the Crohn's and Colitis Foundation website, the European Crohn's and Colitis Foundation, the Canadian Crohn's and Colitis Association. I would say that sites that keep up to date. So I wouldn't necessarily say WebMD. I would say MayoClinic.org, Cleveland Clinic, but certainly the IBD specific patient organizations are going to have up-to-date vetted information that would be super helpful. Nowadays with Google, you can actually Google these scientific papers. I don't necessarily recommend that patients do that, but that they can that they can tell their tell their providers that there are such guidelines out there, and that right now we only have the 2019, but hopefully by the end of 2024, we will have the global consensus guideline in either the OB-GYN literature or in the GI literature.
Just kind of go along with the, mental health and emotional well-being as we wrap this up. This is so critical. What mental health support or coping strategies do you recommend for your mothers to be?
Yeah. So, there's so many emotions that go around this, right? So the stress of getting pregnant, the societal pressures of having a family. An ounce of prevention is worth a pound of cure. So being able to say, listen, that my disease is under good control right now. So let's focus my appointment time on talking about preconception counseling. Because that if you Google preconception counseling, there's good literature to suggest that even spending 5 minutes talking about some of these issues improve outcomes. So, and if your GI provider is not comfortable or not willing or doesn't want to have this conversation, then you might want to think about finding another GI provider. But that it also has to be the OB and the gynae provider. And if that provider says, listen, I don't, you're high risk, you're going to need to be followed by high risk, is that available in your community? Or do you need to be proactive and have a visit with one, a consultative visit with one, so that all of the issues can be talked about up front and so that you can plan? And that, again, Mother Nature has a way of surprising us, right? But the more that you are proactive in this realm, and when I say proactive, I don't mean that you have to, that you have to be thinking about this just because you're a woman. That there are very effective birth control methods out there. And what I famously said at our meeting last year and apparently blew up Twitter or X for a little while was, just because a woman has a uterus doesn't mean she's going to use it, right? So that providers who somehow force the discussion on you. And I find that as well, that well-intentioned providers who are like, listen, this is safe for pregnancy. And this poor patient is just trying to get through her master's degree and isn't thinking about pregnancy at all. And she's got very reliable birth control. She's like, what? I'm not going to get pregnant. Come on. That I asked the question, should we be thinking about, pregnancy for you? Or else just throwing in and by the way, that this therapy is safe for, if you're thinking about starting a family. And that's all it takes is just that added on part of the sentence. But I don't force the conversation if she doesn't want it.
This is a question, and postpartum depression. Any patient could be at risk. Okay. Any patient could be at risk for that. Any pregnant patient or a person that has a baby. Is there any increased risk for patients?
Yes. Thanks for asking. Okay. Yes. So Sonia Friedman has done some really nice work to show that women with IBD are at increased risk for postpartum depression, and that they are at risk for flaring after delivery for up to 1 year after that delivery.
So what is your suggestions and tips for patients and how?
So that okay, everybody's like, phew, great, congratulations, you had a healthy baby. don't take your foot off the pedal, and make sure that you are seeing that patient, whether it's virtually or just checking in with them with a telemedicine visit, because now she's busy with a newborn at home. But I like if it allows, I love for the moms to come in and bring their baby so that I can meet the baby too, and just have a postpartum visit at some point, 4 to 6 weeks after delivery, to make sure that they are on track with their meds, that if there are issues with mastitis, or that they need, that there is other infections, that those things are being addressed, and that they're happy about where they're at with this pregnancy and this family.
Thank you so much for joining us today on this important episode of the Gastro Girl podcast. And a huge thank you to Dr. Sunanda Kane for sharing her invaluable insights on IBD and pregnancy. We hope this conversation has provided you with the information and confidence you need to navigate your pregnancy journey. If you found this episode helpful, please don't forget to like, share, and subscribe. Sharing this episode could help others in our community who are facing similar challenges. And be sure to subscribe so you don't miss any of our upcoming episodes, where we bring you trusted experts, patient stories, and the latest insights on digestive health. Thank you for being part of our Gastro Girl family.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.